So hi everyone, my name's Olivia Stuart and I'm a subspecialist in Reproductive Medicine at Fertility Associates. The original topic of the talk is polycystic ovarian syndrome, which I am going to talk about, but I also wanted to throw in a few other interesting things to talk about, like trends in fertility at the moment and treatment options that we have, as well as navigating the public health system. So hopefully I'm not going to bore you too much in the last talk of the day. So we've come a long way since Louise Brown was conceived in the first IVF baby 38 years ago. And thanks to Richard Fisher and Freddie Graham, who introduced IVF into New Zealand 30 years ago, we've been fortunate enough to create a large number of babies and families in New Zealand. And so the latest local evidence comes from the Dunedin study, where they found that 1 in 4 people, or couples, have concerns with infertility during their lifetime. We know that as women we're only born with our eggs. We never make any more in our lifetime, and in fact our peak egg count is in our early 20s. And this is a logarithmic scale, so by the age of 35 we've got about 10% of our eggs left or less, and then by the menopause, which is usually around the age of 51, we've got no eggs left. So we're constantly battling this as females. What that means for us is that our chances of having a baby go down as we get older. You can see pregnancy rates here along this side, from IVF in the red, from natural conception in the blue, and IUI in the green, and none can overcome the age of the woman as we get older, other than using a donor egg from a younger woman. We also have an increased risk of miscarriage as we get older. And this is largely due to inefficiencies during the meiosis division during our egg formation, where we see an increase in non-disjunction errors, and which leads to an increased risk of trisomies 21 Down syndrome, Edwards and Patel syndrome, so trisomies 18 and 13 as we get older as women. This is the mechanism of non-disjunction during meiosis, during the formation of our eggs, where typically we get half the DNA going into each egg, whereas with non-disjunction, that splitting mechanism is inefficient, and we get two sister chromatomes going into chromatids, going into an egg, which can go on to cause a baby with Down syndrome if it's combines with a sperm, and there's 3 copies of chromosome 21. So we've got a triple whammy as women. Not only is our chances of having a baby going down, but also our chances of a miscarriage goes up, as well as our chances of having a baby with a chromosomal abnormality. Socially, we're delaying having our children till we've had our careers. So we're already starting to try and have a baby when our fertility is already on a decline. Currently, the age of our first baby is in the 30s compared to our mother's generation, where it was in the 20s. Talking about anti-Müllerian hormone. Anti-Müllerian hormone is a hormone produced by the developing pool of eggs in our ovaries. So it correlates the best, and it's the best marker that we have of measuring our ovarian reserve. And so as we get older, our egg count is going down, so is our AMH level. But by doing the blood test for AMH, and we welcome GPs doing this test as well, then correlating it with the normal range for a woman for her age group, and we have these normograms on our website. We can see whether a woman has got a normal number of eggs and normal ovarian reserve for her age. We can see if she's up in the green zone, that she's got a high number of eggs for her age, and this is typically women with PCOS. And also we really like to identify women down here in the red zone who've got a low number of eggs for their age group and a low ovarian reserve. Evidence shows that if you've got a low AMH for your age group, you're likely to have an earlier menopause compared to a woman who's got a high AMH for her age group. So women with low AMH with a diminished ovarian reserve are likely to have an earlier menopause, sort of in the mid to late 40s. We also know that our fertility declines, usually around 10 years before the menopause. So women with a lower AMH are going to have a shorter time to have a bub. This is our website, just showing the AMH graph, and also You can download copies of this graph if we haven't handed any out to you at conferences lately. It also goes through an AMH and how to interpret it. The older man also has issues as well, no matter how beautiful he may be. Men, as they get older, particularly after the age of 45, have a decline in their sexual drive, reduction in their sperm parameters, so lower counts, poorer motility, high DNA fragmentation, as well as having an increase in babies with problems such as autosomal dominant conditions such as dwarfism and schizophrenia, autism. So I just wanted to take you through a case study. Anna is a 30-year-old nulliparous female who's got irregular cycles, so hopefully somebody fairly common that you'll see in your practice. She used to have regular cycles. She got married and her husband's a really good cook, so she's gained 20 kgs and she's had irregular periods since then. She's on fluoxetine. Her partner complains about loud snoring. And on examination, you notice that she's got some facial acne. She's got some signs of waxing her facial moustache and her snail trail. She describes, on asking further about her family history, that her mother and her sister had similar problems. You organise a day 2 to 3 hormone profile. She's got a pretty high LH, and you can interpret this accurately with the E2 being less than 250, and she's got an elevated testosterone. And you do an early follicular phase vaginal ultrasound scan, which shows findings consistent with PCO morphology on scan. So the diagnosis is cystic ovarian syndrome. So the criteria for diagnosing PCOS is the Rotterdam criteria. They were devised in 2003, and there's about 15% of our female population with that. So it's the commonest reproductive condition in reproductively aged women. You need 2 out of 3 of the criteria, which is either irregular periods, clinical or biochemical hyperandrogenism, so acne, hirsutism, or an elevated total testosterone on blood, or PCO morphology on ultrasound scan. So there's a variety of phenotypes, and the thing to bear in mind is that management should be individualised according to the issues for that woman. PCO appearing ovaries on ultrasound scan is pretty common, and it can occur up to 25% of women without PCOS. It's very common in adolescence, so it makes diagnosis of PCOS in adolescence very difficult. It's also seen in women with hypogonadotrophic hypogonadism and other adrenal or excess adrenal conditions such as congenital adrenal hyperplasia or hyperprolactinemia. Early follicular phase.
So with someone with irregular periods, when are we going to try and test that?
Yeah, so we can either wait till they have a period, which is ages, or we can induce a period with progesterone, assuming that they are baseline and they have a negative pregnancy test from day 28 onwards.
And so then you're doing it on day 5 after the period start?
Yes, that's right, yep. So the practice point from this is that PCO appearing ovaries on ultrasound doesn't necessarily equate to PCOS and vice versa. So for GPs, there's a number of guidelines out there. I understand that the Auckland Regional Health Pathways is something that you use. Something that I found really helpful is the Polycystic Ovarian Syndrome GP tool it's an Australasian one which I've got there. It's under the auspices of the Jean Hales Foundation, which is really, really simplistic and helpful. It's largely what I base the rest of this talk on for PCOS. But also, up and coming, there will be accept guidelines coming through from the CREI, so the Australian and New Zealand group of subspecialists and reproductive medicine practitioners for guiding GPs and other obstetricians, gynecologists when it comes to PCOS. That's to come. It'll be coming out in ENDS-JOG. So with regards to PCOS and subfertility, PCOS women can be subfertile for many reasons. They can be oligo and ovulatory, so not ovulating very often, and the egg and sperm just don't get to come together very often. They could have a high BMI, and we know that women, as their BMI gets higher, have a lower chance of fertility. Also, they have a higher preponderance of psychiatric conditions and poor self or negative body image, so they might not be having sex as often. The mainstays of management for the obese PCOS is weight loss, and then we'll talk about metformin and ovulation induction. So prescribing metformin, we obviously prescribe in type 2 diabetics, those with impaired glucose tolerance, to minimise their risks of infertility, fetal abnormalities, and we aim to have a haemoglobin A1C less than 41 preconception. It's also helpful in obese PCOS women to help minimise weight gain, as well as oligo and ovulatory women with PCOS, because it can help to regulate their cycles. And we use an increasing regime as per their tolerance with the GI side effects. Conventional...
How long metformin? How long for?
Continue it throughout, up through pregnancy even. So conventional clomiphene was used as an ovulation induction agent for women with PCOS, but now we're using letrozole as first line for oligo and ovulatory PCOS women. So it works slightly differently. It's an aromatase inhibitor compared to clomiphene, which is a SERM. And the reasons why we use it is that there's good level 1 evidence now of a higher live birth rate, so a higher chance of having a baby from letrozole compared to clomiphene in this group of women. It's more likely to have monofollicular development, so it's not got the multiple pregnancy rate that clomiphene has, so it's about 3% compared to 8%, and we know it's safe. We're currently using it off-label because it's not licensed for use for this function in this country, in New Zealand, and we get our patients to sign consent forms to use it. We know it's safe. It's got a half-life of 45 hours. Women take it the same as they take clomiphene from day 3 to 7 of their cycle. So by the time they're fertilising their eggs and implanting, it's well out of their system. So we're quite certain about their safety, as well as there's overwhelming evidence now that around the world, large centre studies have shown no increased risk of birth defects to babies born from clomiphene letrozole compared to the general population. We talked about the lower multiple pregnancy rate, but there still is an element of letrozole resistance where some women don't respond to low doses of letrozole and we need to increase the dose. So we need to monitor, and we monitor letrozole cycles. We can't monitor with estrogen levels because it's an aromatase inhibitor. It reduces the estrogen levels, so we just use ultrasonographic monitoring. So Anna is working on her weight loss. She's seen a dietitian and a personal trainer. She's on metformin for her impaired glucose tolerance. She's on high-dose folic acid, 5 milligrams a day, and she's had her first letrozole cycle and she's currently pregnant. We need to always bear in mind the high preponderance of mental health issues in women with PCOS, and so regular checking for this is important, as well as the other long-term sequelae, so endometrial hyperplasia and carcinoma. We worry in women that are having less than 4 periods a year that they are at increased risk of this, and so endometrial protection should be considered in these scenarios. The oral contraceptive pill in non-obese and younger PCOS women, obviously not in smokers or older women because of the risk of venous thromboembolism, and where you'd use cyclical progesterone. Also, we need to regularly check cardiovascular risk factors. We advise referring these ladies when they want to get pregnant and they're advanced maternal age, so they're over 35. If they're under 35, ideally they should be and they're overweight, they should ideally be going through an intensive lifestyle intervention, optimising their body weight, healthy eating and regular exercise, and checking that there's no other factors involved, like male factor fertility or tubal factor. We also like to see adolescents, those that have got a rapid onset or a significant clinical hyperandrogenism or virilization where we're worried about other causes, or where the diagnosis is uncertain. So in summary, PCOS ladies represent a heterogeneous group of women, so we need to individualise the management, but however this is a common group of women that I'm sure everybody is familiar seeing in their practices. With regards to fertility, assuming that there is tubal patency and no male factor, then in a non-obese young PCOS woman we'd be using letrozole ovulation induction as first line now. Those that are obese and young, we are using a 6-month intensive healthy eating, exercise and weight optimisation program, and the difficult group is those that are obese and old, and so yeah, trying to target everything at the same time is really where we're at. Okay, so now I'm just going to talk a little bit about the treatment options that we offer at Fertility Associates. We've talked a bit about ovulation induction. We also offer intrauterine insemination, IVF, which you'd all be well aware of, social egg freezing, donor sperm, eggs and embryo cycles, as well as surrogacy. So we're really offering all that there is available depending on an individual person's or a couple's need. We've talked about clomiphene and letrozole, and that's the graph from the meta-analysis showing that letrozole increases the chances of live birth compared to clomiphene. Letrozole also has a better side effect profile than clomiphene because it doesn't have the cumulative negative effects on endometrium and cervical mucus. Intrauterine insemination we're using still, but at a lower rate, with couples that aren't getting pregnant with simple methods. They've got tubal patency, normal sperm or a mild sperm factor, but don't want to be leaping straight into something really invasive like IVF. So it's offering a more natural sort of option for them. And we would expect 40 to 50% of these couples to be having a baby with 4 cycles of IUI. IVF is very much more involved and intensive, and there is a multitude of options now with IVF. And this all depends on the ovarian reserve and the AMH of the lady, which we use to advise on the type of stimulation. Women with normal AMH, we use normal doses of medications because they're normal responders. Women with a high AMH, so the PCOS ladies, they're very sensitive, and we're very sensitive to overstimulation and ovarian hyperstimulation syndrome. So we use a completely different type of cycle compared to a woman with a diminished ovarian reserve and a low AMH, where they've got very insensitive ovaries and we need to use really high doses to stimulate them to respond. Our pregnancy rates compare favourably to the US, which is who we're always comparing ourselves to. We've got advanced sperm selection methods available now for men with a severe male sperm factor, where we know that a conventional ICSI, which is choosing sperm on basically a beauty contest of sperm under low magnification, where we look at typically under 100 times magnification the sperm and then pick the normal looking one. Generally the best looking sperm has got the best genetics, but that's not always the case. We now know that looking under 6,000 times magnification we can find little holes or vacuoles in the sperm head, which is where the DNA is packed for the sperm. And if we choose those sperm, then we've got lower pregnancy rates and higher miscarriage rates. Conversely, if we pick the normal looking sperm on high mag, then we're getting much better pregnancy rates and lower miscarriage rates. So that's one thing we're offering. I had great videos, but they're not working, sorry. Also, we've got lots of embryo selection methods, where these are day 5 blastocysts, and we're growing them out to day 5, where they now consist of 100 to 150 cells. These outer cells around the outside of the trophectoderm, and that's what's going to implant and make the placenta. The inner blobs of cells are the inner cell mass, and that's what's going to make the baby. So we know from doing studies using pre-implantation genetic screening or biopsying the trophectoderm, so the cells that are going to make the placenta, and analysing them for chromosomal abnormalities, that usually on average 50% of blastocysts, day 5 embryos, are going to be aneuploid, 50% euploid. But we also see that this proportion increases significantly as a woman gets older, and that's basically related to the age of the egg. Also in couples with recurrent miscarriage. So we're offering PGS or embryo biopsy. So we're taking out about 6 cells from the trophectoderm, which is going to make the placenta, freezing the embryo, sending these cells down to Canterbury lab. They're analysing all the 24 chromosomes, and then we only replace the genetically normal embryos. So what this is doing for women that are older and for couples with recurrent miscarriages, reducing their time to having a baby because they're not putting all the embryos back one at a time, and they may have no implantation or they might have a miscarriage. We're just putting back the euploid embryos straight away. This is time-lapse or TIMI, which you might have seen on the news last week. So conventional IVF, we take the embryo out of its little happy environment and examine it under the microscope. But there's good evidence now to show that the longer the embryo is out of the incubator, the more detrimental it is to embryo development. And normally with this process we'd see about 25% of embryos develop to day 5. With TIMI or time-lapse, we're putting the embryos into its own incubator with a little camera, which takes a photo every 5 minutes for the first 5 days. We're getting about 50 to 60% of embryos getting to blastocyst stage now, day 5. So we feel that it's better for the embryos. They're staying in their own little healthy environment where they're comfortable. The other cool thing is that people get their own USB with their little video on there so they can see their embryo and show their embryo later on when it makes a baby. The latest test that we have is PREPARE, or it's reproductive genetic carrier screening. So due to public demand, we have started offering this. We can be carriers of genetic conditions, and if we combine with our partner who's also a carrier for the same condition, we can have a baby that's affected, even if there's no family history of that condition in our family. That's happened to us where we've had 2 carriers of cystic fibrosis. We've done IVF and they've had a baby with cystic fibrosis. So there is a lot of these tests coming up now, and they'll be even more commonly prevalent. There's many of them available. This one is the one that we've chosen to go with. It's with VCGS in Melbourne. It looks at the 3 commonest genetically inherited conditions in the Caucasian population. So cystic fibrosis, which has got a 1 in 25 carriage in Caucasian people. Spinal muscular atrophy, which has got a 1 in 40 carriage, and Fragile X, which is 1 in 150. So they're the 3 commonest genetic conditions in Caucasian people. There are many larger ones. This is the one that we've gone with. So it's just a swab of saliva. We send it away to Melbourne. Takes 10 days to get a result. Costs $550. If the woman has got Fragile X, then she can definitely pass it on to her child because it's X-linked. If she is a carrier of cystic fibrosis or spinal muscular atrophy, then we test the partner. And if they are negative, then we don't need to worry about it. If they're positive, then obviously we're sending them off to the geneticists. So I just wanted to talk a little bit about public funding, so I'll zoom through it. But there's 2 steps, and it's really hard to get to grips with. It's taken me 3 years of working back in New Zealand to understand the process. But the 2 steps are often thought of as one. The first step is the one you're largely involved in, which is referring for a first specialist appointment or an FSA. The second part is where a fertility specialist sees whether a couple or a person is eligible for public funded treatment, and that's the second part. So I'll go through this step by step. For the FSA, or the first specialist appointment, that can either be public or private. So the private option, patients can just make their own appointment. They can choose who they see. They don't have to have any tests at all before they see us. When they see us, they'll see a fertility doctor. We'll assess them to see whether they are eligible for public fertility treatment. If they are, put them on the wait list. We'll do a pelvic ultrasound scan. We will talk to them about the fertility treatment options available to them. They will see a nurse as well to talk through those particular treatments if they're interested in anything. So they get all of that at their first private consultation. They can be seen within 2 weeks. Compared to the public, where you'd be well aware of all the eligibility criteria, that you need to do a few investigations before they come along to see us, and the current wait time is about 3 to 4 months from your referral to when they actually get an appointment. You would be aware of the Northern Regional Fertility Service, which is where you write your referrals to, who prefer e-referrals apparently. You would know how to do those more than me. And then they allocate those individuals to one of the 3 units in Auckland, of which we are one, for the FSA. The mandatory requirements in New Zealand is that both partners are residents of New Zealand, have citizenship, or they have at least 2 years on their working visa. Australians don't qualify unless they've shown an intent to stay, such as owning a home. There are other additional criteria. So it used to be a BMI of less than 32 for a first fertility consult. It's actually now 36. So that's an important step. We see it as as helping to not disadvantage particularly Māori and Pacific Island groups. Also, you can refer smokers now. They just have to have a BMI of less than 32 and be a non-smoker to be put on the wait list for public fertility treatment. But to get their first appointment with us, they can be a smoker and they can have a BMI of up to 36. So those are maybe new developments. They always need to be under the age of 40 for the female and can't have more than 2 children under the age of 12 living at home. So even if they've got, if they're a blended family, however number of children under the age of 2, if it's 2 or more, under the age of 12, if it's 2 or more, they don't qualify. Twins are counted as 2 children as well. And you'd be well aware of all the tests that need to be done before the first consultation, but we've got all that on our website as well, which I'll show you where that is at the end. Then comes the assessment of whether a couple qualify for public fertility treatment, and only a fertility specialist can do that. And a couple need to have a score of more than 65 on a CPAC to be eligible. Once they're then put on the wait list, and we can't control their movement on that wait list. They just go on at the bottom and then wait till they come up at the top. Nothing can facilitate speeding you up on that wait list, contrary to other people's beliefs. So this is a CPAC form, and you need to have an objective score multiplied by a social score to get a final score greater than 65. So I thought I'd go through a few scenarios. Unexplained infertility is the hardest to score for public fertility treatment, because they will all score 0 on the causes of infertility. All their tests and investigations will be normal. So then it's 5 years of trying in this country for you to qualify if you've got unexplained infertility. A common group of men that we're seeing coming through is men having their second family. And I'm certainly not saying that these men have had vasectomies. But it's certainly a common group of couples that we're seeing nowadays coming through. We're about 10% of the couples that we're seeing are men having their second family. So even if a man has had a vasectomy before in the past, it is a bit more difficult to qualify, but essentially if they've been trying for more than 3 years and they've got no children at home, then they will qualify. If they've got 1 child living at home from his previous relationship, then it's 5 years of trying. Another common group that we're seeing coming through is single women or same-sex female couples. And so they too can qualify. And recently I had an interesting case where a woman was referred but declined. And in fact, we found out that it had been an incorrect decline, so we were able to overturn that on her behalf, where she'd had 14 home insemination attempts at home without a pregnancy. So she'd been trying for more than 12 months. Then she should have been accepted for an FSA, a first specialist appointment. So certainly it is harder for single women or same-sex couples, where they need to either have a severe factor such as grade 4 endometriosis, bilateral tubal occlusion, but if they don't have any of those factors, they need to have failed 12 IUI cycles before they would qualify, and 6 of those IUI cycles have to be can be home and SEM, 6 have to be within a clinical unit. So now I just wanted to talk through a few scenarios navigating the system, the New Zealand system, public and private. So essentially you can go all public. You can wait 12 months, trying for 12 months before you see your GP, then wait 3 months for your first public appointment. If you need a laparoscopy, then it's about a 6-month wait in the public setting. Have a follow-up in the public at 4 weeks later, and then end up waiting about 6 months once you've been put on the wait list for public fertility treatment before you get your publicly funded IVF. So all up, it doesn't cost you anything, but it's about 27 months wait, so over 2 years. Compared to doing some part of the process privately, so your appointment, your first fertility appointment takes 2 weeks waiting time. You have a public laparoscopy, then a private follow-up with your private specialist, get put on the wait list for public treatment, and your wait time is about 23 months. And the cost is the cost of your 2 private appointments, which is $400. Or you could have your first public appointment in the private, a public laparoscopy, a follow-up in the private, and then private IVF, and your total wait time is 8 months, and the outlay is about $10,000, so the cost of your private IVF cycle plus your appointments. The fastest way, obviously, is going completely through the private system, and you can go from seeing your GP to starting your private IVF treatment in 2 months, with a cost of about $10,000 for your IVF treatment and appointments, plus or minus the cost of your laparoscopy, depending on whether you've got insurance. So that's just food for thought. There is a wait list once you're put onto the wait list for public fertility treatment, and the current wait time is 16 months. Patients can also have private treatment, or if they conceive naturally, then they will come off the wait list, but they just need to come back and see us to be put back on the wait list. It's only once you've got 2 children at home under the age of 12 that you no longer qualify. So certainly having a baby naturally or through private treatment doesn't mean that you don't qualify for public fertility treatment anymore. You just need to be put back on the wait list before you turn 40. There's also a second publicly funded package, and so women need to be rescored for that by a fertility specialist. You're only eligible if you don't have a baby from your first public package and you haven't turned 40. All the same eligibility criteria apply. The wait time is less to your second public package, usually about up to 6 months at the most, and you have your second cycle in the same unit as your first cycle. On the horizon, male smokers will soon, if the male partner is a smoker, I think actually if the partner, whether they're male or female, is a smoker, they will no longer qualify for public fertility treatment because of the halving of pregnancy rates and the more than doubling of miscarriage rates if the other partner is a smoker and the carrying partner isn't. That's how detrimental it is. So that's coming in soon. They're thinking of making unexplained infertility more able to be accessed for this group of couples, so bringing it down from 5 years of trying to 3 years of trying. And they're also looking at laxing the BMI for public fertility treatment to 36. So that's what's on the horizon. Fertility preservation, we see all the child cancer sufferers under the age of 16 in Auckland at Fertility Associates. The adult patients are immediately referred to one of the 3 units according to their date of birth and month. So this is an image of our website. The important thing to highlight is information for GPs up the top there. Also booking a free nurse consultation, which your patients can do at any time. It's completely free and they get 15 minutes speaking to one of our nurses. AMH is talked about, as well as accessing public funding and the genetic carrier screening. Basically everything is covered in that information section for GPs.